And you know, states now, most states, are doing a prescription drug monitoring program. That's regulatory. And I think that the purpose, I know the purpose of this was to stop doctor shopping, right? To go Dr. A, Dr. B, Dr. C, and pretty soon you're getting 4, 5, 6 times what you really are supposed to be getting. Has this really worked? And if not, what steps do you think we need to take to make it even more effective?
So we're early on in the phase of these PMPs, prescription monitoring programs, or PDMPs, prescription drug monitoring programs. So we don't really have the outcomes data. But if you think about it, Peter, it has to work. I mean, it's really changed the face of our practice. When a patient comes in the office, we could do a 30-second, 60-second query online and see what medications are they getting, from what pharmacy and what doctor prescribed them, and on what dates. I mean, that's changed the face of practice because we can now ferret out the doctor shoppers. So even though we don't have the data yet showing that it's made a difference clinically, we know that it's going to help.
Kind of passes the smell test.
Sure.
I'll add one thing to that, though, Peter. I think some of these prescription monitoring programs do not take into account prescriptions that are delivered at the level of the physician's office, particularly with workman's comp. And so I think for it to be a true comprehensive program, whenever a patient is prescribed an opioid, particularly in those dispensing situations from the physician's office, that should also be tracked. And I think right now, I know at least certain situations it's not.
That's a big loophole.
That is.
And I would also add that it needs to be real-time prescription monitoring. I believe that many state databases, there's a lag of 2 to 4 weeks before they're updated. And that's a lot of opportunity for the patient to doctor shop and collect the pills.
You know, you got to be quick and you've got to be ill-intentioned to do that within 3 to 4 weeks, but people are clever.
You know, it's not even clever. You know, sometimes too, it may be a patient who just doesn't realize. You know, they'll get a prescription, particularly if it's a short-acting opioid, after an acute, painful type of situation, and sometimes they just don't know the difference.
And then there are different formulations now,
Right.
right? I mean, the big pharma has taken notice of problems here. They're changing the way they formulate some of these drugs.
That's correct. You know, with the new abuse deterrent type formulations, there are different platforms that are out there. They can start off with crush-resistant type technologies. I think that the FDA now, when they put out a request for guidance, input for guidance, for the various abuse deterrent type formulations, I think it was an excellent move from public policy. And I really applaud them in the sense that they recently took one commonly prescribed extended release opioid with this type of technology and have backed it from the sense of approving it as a crush resistant opportunity.
That's called what, a hardened form of it? What does that mean?
Right. There are various different types of abuse deterrent formulations that are out there. They either can be a crush-resistant technology, or where they may combine them with another agent that may again try to deter abuse. They may include other compounds like an antagonist-agonist type mixture, and as well as prodrugs. But there are about 6 or 7 different types of opportunities to hopefully present an abuse deterrent platform.
So the sense is that we're all moving in a direction which should limit availability of inappropriate doses, to track who's getting what, and if I hear you correctly, it's to regard pain therapy as perhaps self-limited. It's like any other disease. You treat it while you need it and stop when you don't. Is that fair?
Well, one of the biggest challenges, Peter, is that chronic pain is a disease that we haven't yet found a cure for. So it's not always self-limiting, and it's sometimes progressing in the case of cancer pain and some other degenerative conditions. Right. So it becomes quite a challenge. To add to what Joe was saying is that I think that pharma is now moving in the direction of using technology to help with a clinical problem that we face each and every day. How are we going to stop the misuse, abuse? How are we going to limit the diversion? And believe it or not, the term they use in the studies is likability. Right? They take these recreational addicts and they measure how likable is the drug. And the whole goal of these new technologies is to limit the likability to the non-patient, but yet maintain the efficacy for the patient.
In layman's